Welcome. This activity is intended for U.S. healthcare professionals only. The following presentation from Answers in CME is part of an educational activity titled From Evidence to Practice, where do BCMA bispecific antibodies and anti-CD38 monoclonal antibody combinations fit into community care for relapse refractory multiple myeloma. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported by independent educational grants from Johnson & Johnson and Regeneron Pharmaceuticals Incorporated.
Hello and welcome to From Evidence to Practice. Where do BCMA bispecific antibodies and anti-CD38 monoclonal antibody combinations fit into community care for relapse refractory multiple myeloma? My name is Jesus Verdeja. I am the Director of Myeloma Research at the Greco-Hainsworth Tennessee Oncology Centers for Research.
And my name is Saad Usmani. I'm the Chief of the Myeloma Service and Professor at Memorial Sloan Kettering Cancer Center in New York.
These are my disclosures, and these are Dr. Usmani's disclosures. These are the educational objectives which you should have available. And this is a CME accredited hour brought to us by Answers in CME. And please make sure you complete an evaluation to receive your credit. Please realize that there is a Q&A with the faculty, and you're able to actually submit questions throughout, but we'll also have a Q&A at the end if you want to wait till that time as well. And without further ado, we will start our program. Dr. Usmani, perhaps you can shepherd us through the rationale for combining anti-CD38 monoclonal antibodies and BCMA bispecifics.
Thank you so much, Dr. Verdeja. It's a pleasure to be here. And let me just start by discussing the current landscape with anti-CD38 monoclonal antibody therapies. It's really remarkable where we've come from and where we're headed in the field. Currently, we actually have two different anti-CD38 antibodies, daratumumab and isatuximab, that are approved for frontline treatment strategies as well as in the relapse refractory setting. So if you look at the guidelines for the newly diagnosed setting in the transplant eligible population, we have dara-VRd and we have isa-VRd in the transplant eligible patient population with isatuximab. In the transplant ineligible patient population, we have DRD, based off of the MAIA clinical trial, and DVRD from the Cepheus clinical trial, with isatuximab, VRD being there. It got regulatory approval based on the IMRA's clinical trial data. In the relapse refractory setting, there are several daratumumab-based triplets, and more recently, the teclistamab daratumumab combination. But that the whole triplet experience in the relapse setting started with DVD, DRD, subsequently with DPD and DKD. And so with isatuximab, we also have the ISA-KD and ISA-PD combination. So several combinations have kind of become the staple for clinical use for our patients in both the frontline as well as in the relapsed settings. So, if you look at the bispecific antibodies in particular, with teclistamab being the first BCMA-directed bispecific that was FDA approved, I think what we've come to know is they're highly effective for patients who have late relapses, 4+ lines of treatment. We have three products in the that target the B cell maturation antigen, or BCMA, with teclistamab being the first one, showing 63% overall response rate, the median PFS around 11 months or so. Elranatamab, based on the magnetism clinical trial experience, 61% response rates, about 17 months of median PFS benefit, with linvoseltamab being the more recent FDA approval that came last year, 71% response rate, with the median PFS that has not been reported yet. Talquetamab was the first GPRC5D directed bispecific antibody that showed a response rate of around 70 odd percent, with the higher dose of 0.8 milligram per kilogram showing a median PFS of around 11 months or so. So several of these options are available to us in clinic, and we have to pick and choose them based off of where our patients are. So with that in mind, I'm going to ask Dr. Jesus Verdeja to perhaps talk about the rationale for combination therapies.
Yes, actually,
And just give some comments around it. I just wanted to invite you, and then maybe before I proceed with this next next section. How about that, Jesus?
uh,
So
yes, please.
all right. So the rationale to combine the anti-CD38s and anti-BCMA bispecifics lends several advantages. One is mechanistic, the other is being more patient-friendly in terms of administration. So from a mechanism of action perspective, the anti-CD38 antibodies are naked antibodies. They rely on both the usual immune-mediated mechanisms such as ADC, ADCC, ADCP, and complement-mediated cytotoxic cell kill. But they can also target the CD38 positive immune suppressive B cell, T cells, and MDSCs. And that enhances the CD8 positive T cell cytotoxicity. And that's why they can make a very good partner for a T cell redirecting strategy, as you see in this figure right here. So the bispecific antibodies have the ability to recognize two different antigen, BCMA being the target on the myeloma cell surface, and then CD3 being the target on the T cell. So essentially, you're bringing the T cell to do the cell kill. So if you are suppressing the CD38 positive Bregs, Tregs, and then redirecting the CD38 positive T cells towards myeloma cell kill, that can enhance the ability of the T cell redirecting antibodies or bispecific antibodies. So the other major advance with this kind of an approach is this is an antibody-based treatment strategy. You're doing away with the conventional chemotherapies and other mechanisms of actions, and that the patients may have been exposed to in the past in the frontline setting. So with this being said, let's try to test your understanding with the first question. So what is the primary clinical rationale for combining anti-CD38 monoclonal antibody with BCMA targeting bispecific antibodies in patients with relapsed refractory multiple myeloma? Is it anti-CD38 monoclonal antibodies enhance T cell cytotoxicity via immunomodulation, boosting BCMA bispecific activity? Is it anti-CD38 monoclonal antibodies enhance BCMA expression via immunomodulation, improving BCMA bispecific binding? Is it by BCMA bispecifics reduce CD38 expression on T cells via immunomodulation, preventing T cell exhaustion? Or is it BCMA bispecific suppress T cell cytotoxicity via immunomodulation, thereby boosting anti-CD38 monoclonal antibody activity? So please go ahead. All right, looks like majority of you are picking the right option, which is anti-CD38 monoclonal antibodies enhance T cell cytotoxicity toxicity via immunomodulation, thereby boosting the BCMA bispecific antibody. That's the correct answer. With that, whoever picked the answer gets a special prize, I guess, which is bragging rights once you go off the CME program. We'll wait a little bit and then move on to the next section here, which is emerging efficacy signals for bispecific antibody anti-CD38 based combination regimens. And I'm going to hand things over now to Dr. Berdeja.
Thank you, Dr. Usmani. So I think this slide just kind of points out that right now there is one approved combination with BCMA bispecific antibodies and anti-CD38 monoclonal antibodies, and that is teclistamab with daratumumab. But that's not to say that that's the only combination that is going on with monoclonal antibodies. And as you can see, there's actually pretty much all of the bispecific antibodies are being looked at in combination one way or the other with anti-CD38 antibodies, with IMiDs, et cetera. So I'm actually going to go through a little bit of the data with some of these emerging combinations. So here is what we call the linker MM2 study, which is with linvoseltamab, which is one of the BCMA bispecifics with daratumumab or isatuximab. And this is a phase 1b study. And it's in relapsed refractory patients after 2 or 3 prior lines of therapy. And you can see that actually the overall responses are quite impressive. But I think what's even more impressive is if you look to the right, that basically all of the patients that are evaluable for MRD are negative. So we're seeing a depth of response that we haven't really seen before with our other combinations, or at least in the majority of patients. It tends to be that usually it would be in the minority of patients that we would see MRD negativity in the relapse refractory setting. You also have similar combinations with elranatamab in the magnetism program. And so this is results from magnetism MM5, the part 1, which is elranatamab and daratumumab in patients with relapsed refractory myeloma after 3 or more prior lines of therapy. And you can see a very nice overall response rate of 70.6%. And so what's going to happen in part 2 of the study now is they're going to look at 3 sort of kind of groups, and one's going to be elranatamab alone, one's going to be elranatamab with daratumumab, and one is going to be what we consider standard of care for a lot of these patients with daratumumab, pomalidomide, and dexamethasone, and the patients will be stratified to the prior lines of therapy, 1 versus 2 to 3. So again, this will be earlier than the part 1 patients, and then also stratification based on whether the patients have had prior anti-CD38 antibody, which is obviously very important. Similarly, this is data sort of kind of that led to the MajesTEC-3 study with MajesTEC-2 and TRIM2, again, combinations of teclistamab with daratumumab and one with pomalidomide. Again, seeing both in earlier relapse, 1 to 3 prior lines, and later relapse population of 3 or more prior lines. You see that, again, the responses are quite good, very deep responses. And of course, these are leading to what we now are seeing in the phase 3 trials. I think our life changed quite a bit this December when the MajesTEC-3 study results were presented at ASH. And so this was the MajesTEC-3 study, which looked at patients. It's a phase 3 study that randomized patients to 2 antibodies, teclistamab or daratumumab, versus standard of care, daratumumab, pomalidomide, dexamethasone, or daratumumab, bortezomib, dexamethasone, in patients who had 1 to 3 prior lines of therapy. So a large study of 587 patients, primary endpoint progression-free survival, and you can see the curves are dramatic. So the top curve is the double antibody, the Tec-Dara combination. You see at 36 months, 83.4% of the patients were alive and in response compared to 29.7% of patients with standard of care, and that's a hazard ratio of 0.17. So a significant, I think, difference compared to what most of us consider actually a very good standard of care. And if you look at the median PFS of the standard of care, it's 18.1 months, which is actually almost outperform what we saw with the original phase 3 studies that got DPD and DVD approved. So again, these results are not because the patients were faring worse with the standard of care. You look at sort of secondary endpoints, we're starting to see an overall survival benefit as well with Tec-Dara versus DPD, DVD with a hazard ratio of 0.46. And again, on the right, we see the MRD negativity, again, looking at the depth of response. And you see that the Tec-Dara combination led to much higher percentage of patients achieving MRD negativity compared to the standard of care. So how do these efficacy data now compare to established standards of care regimen in relapsed refractory myeloma? And I'm going to ask Dr. Usmani to sort of kind of lead us through this section.
No, thank you so much, Dr. Bedeha. We have several options that have been reported, in the early relapse setting, looking at different modalities targeting BCMA. I think the first one that you see on the slide on the left is the CARTITUDE-4 clinical trial that looked at the BCMA-directed CAR T-cell therapy, cilta-cel, compared with patients receiving standard triplet regimens, DPD or DVD, demonstrating superiority in terms of depth of response as well as progression-free survival in favor of cilta-cel, and this led to the change in label and approval of cilta-cel to patients who have received one or more prior lines of treatment with lenalidomide. Then we have the DREAM7 clinical trial that showed both PFS and overall survival benefit in favor of the belantamab mafodotin bortezomib dexamethasone combination compared to daratumumab bortezomib dexamethasone. Just to remind everyone, belantamab mafodotin is a BCMA-directed antibody drug conjugate, it is not an immune-mediated mechanism. It's a different, it just delivers the toxic drug payload to the BCMA-positive cells. But these results were, quite remarkable when they were reported at the time. Then, of course, we have the MajesTEC-3 clinical trial that has demonstrated perhaps the best hazard ratio that we've seen in any multiple myeloma clinical trial in quite some time. 83.4% 3-year PFS rate, and when we look at DPD and DVD, it's 29.7%. So very remarkable results in early relapse, and they also pose an interesting conversation with our patients on which options would be the best for them. Let's take a look at the patient characteristics of each of these clinical trials, because they are going to be important as we think about which options to pick for patients in what scenario. So if we look at the CARTITUDE-4 trial, it's 1 to 3 median prior lines of treatment, with the median being 2. With DREAM7, it was 1 or more prior lines of treatment, with median of 1 prior line for majority of patients. And then for MajesTEC-3, it was 1 through 3 prior lines, with median prior lines being 2. Looking at lenalidomide refractoriness, it was seen in essentially all patients in the CARTITUDE-4 patient population, whereas prior anti-CD38 antibody exposure and or refractoriness in 26% of the patients. In DREAM7, a third of the patients were len refractory, with only 1% being exposed to anti-CD38s. That's because the standard of care arm here, I guess, was DVD, and that's how the protocol was written. Similarly, with MajesTEC-3, 83% of the patients were len refractory, but 5% had prior anti-CD38 exposure. If we look at the proportion of patients who had high-risk cytogenetics, they were somewhat similar, I would say, across the 3 arms, with variability in patients who had extramedullary disease, 21% in CARTITUDE-4, although if I remember correctly, this did include some paraskeletal, patients as well. In DREAM7, low percentage, about 5%, and in MajesTEC-3, around 14%. And they were primarily soft tissue plasmacytoma, so kind of like extramedullary, true extramedullary disease. So, you have to keep these, options in, or these characteristics in mind as you think about, what are the best options for any given patient in your clinic. What about the other approved combination therapies in this space? This is, again, quite a remarkable story, for us, because we have come a long way from looking at the triplet versus doublets, that those clinical trials that we were evaluating in the mid 2010s going into 2019, 2020, to where we are now in the field where the median PFS for the tech dara combination still has not been reached. So we've come a long way over the course of time from these therapies, and the depth of response in MRD negativity also continues to get better over time. So let's talk about what you've learned from this experience so far. Let's test your knowledge. So we have a 70-year-old patient with multiple myeloma who's experiencing a relapsed after frontline treatment. Which of these BCMA bispecific and anti-CD38 combinations would you consider for this patient given recent approval based on demonstrated efficacy in phase 3 clinical trials? Is it elranatamab daratumumab combination? Is it linvoseltamab with daratumumab? Is it teclistamab with daratumumab? Or is it linvoseltamab with isatuximab? So please go ahead and answer. All right, so we can see that you all have been listening to us, and picking the correct option here, teclistamab combination with daratumumab, based off of the Majestic 3 clinical trial. All right, then we are going to talk about the safety profiles. So looking at BCMA bispecific anti-CD38 combinations in relapsed refractory multiple myeloma, and going over the safety data next, and turning things back again to Dr. Bedea.
Thank you, Dr. Usmani. And I think this slide could be set for all bispecific antibodies and CAR T therapy. So anytime you're activating T cells, you're redirecting T cells, you have the potential to get cytokine release syndrome, immune effector cell-associated neurotoxicity syndrome, or ICANS. And then anytime, of course, you're targeting plasma cells in general, but BCMA and other very potent targets, it leads to potential infections and cytopenias. So if we look at the sort of the new approval of from Majestic 3 with Tecdara, and we compared it to the initial approval of teclistamab with Majestic 1, and we kind of put those 4 different toxicities here in the table, you actually see a very similar sort of pattern. So there seems to be very little added toxicity by adding the anti-CD38 antibodies. So the CRS is 60 to 70%. I'm going to skip infection, that'll be the last. Neutropenia is similar. And again, the neutropenia tends to be early on for most of these patients, often clearance of bone marrow, and then that improves. ICANS that we see with CAR T cells a little more, we see very little in the bispecific antibodies, and the combination doesn't seem to have any added effects. When you look at infections, I think this is probably the most problematic toxicity for these bispecific antibodies by themselves or in combination. You see that actually the majority of patients in Majestic 3 did have an infection, with 54% being grade 3 or more, which is actually not too dissimilar from the grade 3 or more infections of just a monoclonal or just a bispecific alone. But I think what's interesting is in parentheses, you see the infection rates of these control arms with the patients with DPD or DVD. And let's not forget that daratumumab combinations still, again, given the targets, given the fact that these are myeloma patients, often will induce infections. And you see that 84% of patients had infections with 43% grade 3 or higher. It's definitely higher with the bispecific, so I'm not going to downplay that at all. But I think it's reassuring to see that at least it doesn't seem to be any significant worsening of this problem compared to the monoclonal or to the single agent bispecific. When we look at the other combinations that are ongoing, again, with other bispecific antibodies, and so here you see linvoseltamab with DARA or ISA compared to linvo monotherapy on the left, with the linker MM2 and MM1 studies. And then on the right, you see magnetism MM5 versus MM3, so the combination of Elra-Dara versus Elra monotherapy. I think you can pretty much go down each of the rows and see basically very similar numbers. So again, alluding to the fact that there's really no significant increase or toxicity with any of these parameters when you do the combination compared to the single agents. So in terms of, we know we have these toxicities. So now let's talk a little bit about managing these toxicities. And I'm going to pass it on to my colleague here to take us through some of these.
Thank you, Jesus. So, let's try to focus on a couple of important aspects of this regimen, and there's somewhat interrelated as well. So, one important thing is managing cytopenias. So, monitoring patients with complete blood counts, providing growth factor or transfusion support, as well as managing the treatment schedule for patients. And the same is true for the infections as well. So we need to make sure that we treat patients with appropriate antimicrobials. Many of our patients do develop hypogammaglobulinemia. So IVIG supplementation would be something that has to be employed as an important supportive care measure. And then the use of IVIG really depends on um, uh, the prior history of infections in patients as well. So, I see that there is, a question about preemptive use of IVIG or waiting for recurrent infection. It really depends, of what kind of infection profile the patient may have had in the past, whether they're young or old, whether, they have other comorbidities that would increase their propensity, especially for respiratory infections. But in general, if the total immunoglobulin is declining and about to hit 400 or lower, I think we are more trigger happy to actually start IVIG in those patients, even in absence of infections. Then antimicrobial prophylaxis, including acyclovir or valcyclovir for VZV, and then for PJP, having them on Bactrim would be important. And I have to say that the risk of infections with biospecifics, is a little bit, higher because of continuous therapy model compared to our CAR-T patients. So it's something that we pay very close attention to. What about the management of CRS and ICANS? Most of our early experience with CRS and ICANS, again, was in the cellular therapy, domain, but, cytokine release syndrome is observed in, a little more than half of the patients who get bispecific antibodies. Most of that is typically grade 1, some grade 2. But we tend to treat with tocilizumab, with or without corticosteroids. And now, we are starting to use pre-medications that include, either steroids or tocilizumab as well. So that risk is typically with the first, step-up doses or one full dose. And so, step-up dosing has minimized CRS risk, and that's why it was introduced in clinical trials. And for appropriate patients, I think typically hospitalization is recommended, but then many of us are starting to use bispecifics in the outpatient setting with appropriate prophylaxis medications as well. ICANS, typically not as common with bispecific antibodies as with CAR-T cell therapy. It's honestly less than 5%, and even if it happens, it's very transient and very manageable. And hopefully this addresses this second question that just came through about how often are we seeing neurotoxicity for our patients? It's not very common. In fact, in some of the bispecific trials, it's actually reported as 0 or 1%, and in some at 2 or 3%, and almost all of it tends to be grade 1. So checking I-score, handwriting regularly during step-up dosing is something that we do, and the first line of treatment is corticosteroids for those patients. So very different kind of a profile to a CAR-T cell, therapy patient. So how do you work up a fever and distinguish whether it's due to CRS or infection, during the step-up period? You do work up for infections, but the first step is you offer tocilizumab and steroids to control the CRS symptoms. And if it's not getting better, then you think more about maybe infection would be a culprit. After the step-up dosing, you have to think about infection first, because the likelihood of CRS is lower, in fact, almost negligible after the first full dose typically, but, it kind of goes more on the lower priority on your differential, after that initial step-up dosing. All right, so let us test your understanding of this section now with this next question that Dr. Bedeha will ask you.
Thank you, sir. Before I ask the question, I just wanted to say, though, I think we all know we're so used to grading of CRS, but just to put it in context, CRS grade 1 is a fever, isolated fever with nothing else. I would argue that a neutropenic fever is probably more dangerous for patients than just a CRS grade 1. So just kind of keep that in mind, that we are truly talking about low-grade CRS, and it's the potential development of the higher grade that is worrisome. But I think for most people, it's a pretty benign sort of kind of process, especially with Dr. Usmani's step up that he showed you before. So anyways, let's move on to the question. So it's a little bit related. So you have a 67-year-old patient with relapsed refractory myeloma, develops a fever of 102 24 hours after initiating step-up dosing with an anti-CD38 monoclonal antibody plus BCMA bispecific antibody combination. She does not demonstrate any other signs of infections, suggesting this may be cytokine release syndrome. So how would you manage this patient? You treat with supportive care, including fluids, initiate infectious workup, treat with sarilumab, initiate broad-spectrum antivirals, treat with tocilizumab, initiate infectious workup, treat with tocilizumab, and initiate broad-spectrum antivirals. So go ahead and answer here. Once again, this is a pretty savvy group, so it's everyone seems to be getting the right answer, which is treat with tocilizumab and initiate infectious workup. And I don't usually start even antimicrobials unless the patient's neutropenic as well. Otherwise, I think just initiating the workup is sufficient with this. The other thing I will note is that one of the nice things about treating with tocilizumab, because I think in myeloma we're a little more toci heavy than other specialties, is that once you have cytokine release syndrome and you treat with tocilizumab, you basically have no recurrence of cytokine release syndrome. And so that's, I think, one of the added benefits sometimes of using tocilizumab, in my opinion. But we'll move on to the next section at this point, which is basically sort of kind of where are we going from here now that we have this approval, what's next? And so Dr. Usmani is going to take us through sort of how we select patients for some of these treatments.
Thank you, Dr. Bedeha. So typically, when we think about patients who are relapsing, we kind of clump things in certain buckets, and those buckets, are help us in that decision making and having discussions with our patients. So, from a inclusion criteria perspective, it's important to pay attention to which patients were included on those trials. So, prior lines of treatment, as they were mentioned in trial, whether patients were PI or IMiD refractory, and then what would be the washout period for the anti-CD38 antibodies. And then, if you look at, this clinical trial, just one second. I think, Dr. Bedeha, you're getting the same notifications. I'm just turning my notifications off. Apparently, there's some exciting data being presented at a conference. In the Majestic 3 clinical trial, patients were not allowed to have prior BCMA therapies. ADCs are not included in some trials, but prior BCMA was. Patients couldn't have been refractory to anti-CD38s, but prior exposure was included. And then, patients must not have had live attenuated vaccines just prior to therapy. Again, speaking to the potential of, potentiating, complications, for patients, who are going to have their immune system quantitatively and quantitatively essentially declined, function. So with this in mind, let's take a look at the appropriate patients who benefited from or who would potentially benefit from these kind of strategies. Patients who have soft tissue plasmacytomas, high plasma cell burden, patients who have high risk cytogenetics, different number of prior lines of treatment, refractoriness to prior IMiDs and PIs with anti-CD38 exposure. Those are the patients that have kind of been examined in each of these, clinical trials. But look at the percentage, of patients. In TEC3, it's about 5% of the patients. In the Linker MM2 clinical trial, looking at the Linvo with Dara ESA experience, there is a little bit of a higher percentage of patients, with that experience. But we don't know what the phase 3 eventual design will enroll, but it's something to pay attention to. In the phase 3 magnetism trial, which is just the ELRA monotherapy, these patients made up about 27% of the population here. So when we're thinking about treatment selection considerations amongst the three classes of anti-BCMA therapy approved for early relapse, what are the potential implications? And to take us through some of that, especially in the context of what kind of side effects to expect, Dr. Badeja will walk us through that.
Thank you, sir. And here I think it's a nice sort of comparison between the three BCMA-directed therapies, either single agent or in combination, that we're using in second or third line for patients with myeloma. So you have cilta-cel, which is the CAR-T from CARTITUDE-4. You have the Tec-Dara combination from MajesTEC-3 in the middle, and then you have belantamab mafodotin or bortezomib-dex from DREAMM-7. And I think if we the Dr. Usmani mentioned earlier, I think the first two are truly that T-cell redirection type therapy. So the type of toxicities we see is very different from belantamab mafodotin, which is more of a targeted payload delivering system. So if you look at cilta-cel and Tec-Dara, you see that, again, CRS is very common with both. But then you also have that sort of green curve there, which is ICANS, which again can be seen with both, but really is much more likely to happen with CAR-Ts. And those sort of kind of higher grades are rare, but some of the delayed neurotoxicities are more common with CAR-Ts, rarely seen with the bispecific combinations. Cytopenias are very similar in both, but then when we look at the actual sort of gray bar, that's sort of where we see a little bit of a differentiation. And this is grade 3 infections, which are more common with the Tec-Dara or the bispecific combinations compared to even CAR-T cells. I think with CAR-T cells, we are used to seeing these infections and are highest risk in the first 6 months or so, but then they start to attenuate, as opposed to with the bispecific antibodies, where because of the continuous therapy of our current way of delivering them, we see this continued potential for infections. With belantamab mafodotin, you don't see CRS or ICANS. You do see some infections and neutropenia, maybe to a lower degree, but you start seeing ocular events. And again, that has to do with the payload, and that is sort of kind of what complicates this therapy, with patients need to be seen by optometry, ophthalmology before each dose of belantamab. So in terms of sort of, so which is the most appropriate patient for each of these drugs, there's no right answer. But I think it's fair to say that for the antibody drug conjugates, so belantamab mafodotin combinations, that tends to be, in my opinion, sort of the most, sort of the least toxic therapy for patients. I think it's the easiest one. It doesn't require access to an academic center. So I think for a patient population that has a hard time traveling, or the support may not be there, I think that's a great combination for those patients if that is off the shelf. But it does require multiple dosing. But again, there's no need for hospitalization, obviously, unless the patient has an adverse event that requires so. With the bispecific antibodies, I think the benefit of that is that it's off the shelf, so you can treat immediately. And you see these very rapid responses. So a patient that actually has rapidly progressing disease, I would favor over a CAR T, for example, because again, I can get control of that disease quickly. It does require multiple dosing, which is that's a negative. And the hospitalization during the step-up dosing is in the package insert, but I think we're starting to move away from that, and I think a lot of centers are starting to do outpatient dosing altogether. But nonetheless, you still require some proximity to a specialty center or to a hospital. And then you have CAR T-cell therapy, which I think the biggest thing, we always talk about CAR T-cell therapy, is the one and done potential where patients get to come off therapy. But we're starting to learn that if we want to make CAR T-cell therapy more manageable, more effective, you really want to take patients who have control of their disease. So we need to either do it as consolidation, or if a patient has rapidly progressive disease, they need to be able to respond to bridging therapy as you're waiting for the manufacturing of CAR Ts, or perhaps maybe that patient should not get a CAR T. And this therapy still requires a specialized center, and so it does limit sort of its access. So I think from a standpoint of sort of accessibility and effectiveness, I think the bispecific antibody anti-CD38 combinations are very effective and have very convenient scheduling that I think will allow for more potential for community embracement and access compared to CAR T therapy. So let's move on to question number 4. And so you have a 72-year-old patient with relapsed refractory multiple myeloma who's being considered for next-line treatment after 2 prior lines of therapy. Which of these represents a benefit of combination BCMA bispecific and anti-CD38 monoclonal antibodies over CAR T-cell therapy in this patient, particularly in the community setting? So more durable remissions and a convenient schedule, lower risk of infection and accessible in community practice, no need for hospitalization and convenient schedule, or accessibility in community practice and a convenient schedule. Please go ahead and answer. So it looks like most people are picking the right choice, which is the last one, which is accessibility in community practice and convenient schedule. I would just more durable remissions, that's still to be determined. There's higher risk of infection, so that's not the right answer. And there's still a potential for hospitalization, so we can't choose 3. So 4 is the correct answer. So we'll move on. So in terms of sort of where we're going with this, obviously, as everything in myeloma, once we test it in the relapse refractory setting, we go to the early relapse, and then we go to frontline. And so there are several studies ongoing in both transplant eligible and transplant ineligible patients, looking at bispecific combinations, either as monotherapy or in combination, as you can see here with daratumumab, lenalidomide, or as a quadruplet with daratumumab, bortezomib, lenalidomide, and then the transplant eligible with similar combinations as well. And then also looking at it as consolidation following, for example, a transplant, where you're looking at fixed duration therapy as in the immunoplant study, or testing it against standard of care, lenalidomide continuous therapy, for example. So all those studies are ongoing, and I think those results will really reshape how to best use these bispecific antibodies. So I think now we can pause a little bit. There's a few questions, and also just sort of, I guess, kind of both Dr. Usmani, maybe, and I can come off mute, and we can talk about, how do we decide, and I guess I'll ask a question of Dr. Usmani. So since it is a question over here, so in a patient who is refractory to an anti-CD38 antibody, is this a patient that you would still give Tecdara?
Yeah, so my preference would be to first think about when they were, how long ago were they refractory? Are they just coming off of data right now? Were they responding to data for many years before coming off, or progressing? All of those, are important nuances. For functional high-risk patients, who are progressing within the first 2 years or so of initial therapy with an anti-CD38. My preference for that kind of patient would probably be cilta-cel rather than um, you know, um, teclistamab. However, if someone is not, CAR-T eligible, or they're not functional high risk, or they've been on data for a while and they're just starting to show biochemical relapse, I would be comfortable with offering them teclistamab, step-up dosing while continuing the daratumumab. Because there I feel, the other mechanism of action would probably be more important. If someone had prior dara exposure or isatuximab exposure, and they've been off for a while, and they don't want to go for a CAR-T as an option, or are not CAR-T eligible, I think it's reasonable to start them on tech data in that scenario. So that's how I would be thinking about this. Well, how about you, Jesus?
Yeah, no, I completely agree. But I think one of the things we didn't really talk about was sequencing, right? So, we have all these BCMA directed therapies, and I think we're starting to learn that sequencing does matter, and the ability to use a CAR T after a bispecific or vice versa is very different. And I usually like to tell people, or like to say that if a patient is eligible for all three modalities of therapy, then I would usually go with the CAR T first, because I think the CAR T, or the efficacy of some of these other therapies after CAR T, progression after CAR T, seems to be preserved, but not always the other way around. And so that's one of the, that was one of the questions, is can you use a CAR T after doing something like Tecdera? Again, we're still learning a lot, but it seems like the results are not as great. So I think it is still important to call Dr. Usmani and say, hey, I have this patient, and together make the decision about which one do we choose, because it does impact what other therapy this patient may be eligible for. Yeah. All right.
Looks like we have a few questions.
Yeah. So well, we kind of talked about those two questions, and then the
Yeah.
only other thing is that keeps coming back up is the IVIG question. So you answer that, and I will just say that at least with bispecific antibodies, for sure, I really do feel that these are such potent therapies that I usually are very preemptive, and I just start IVIG as early as after step up for these patients preemptively. There are some studies showing that use of IVIG that way has led to decreased infections for some of these patients. Having said that, of course, as a patient goes into remission, cytopenias improve and so forth, and we start pulling back the frequency, sometimes we do see decreased infections as well. But I'm very aggressive with IVIG use, and I'm curious, Saad, if you agree with that or not.
Yeah, so I think for respiratory infections, IVIG, does play an important role. I'm enthusiastic about IVIG use, in general, in patients who have already demonstrated that they have a lot more respiratory infections. I'm a little bit more judicious in patients who have not had a run with respiratory tract infections, and maybe just watch them a little bit before initiating the IVIG. The one important thing that I always highlight, and this is something that I share with my fellows and colleagues as well, is the IVIG only helps with certain viral infections and some encapsulated organisms, and primarily that data comes from the pediatric experience, and it's mostly respiratory. It's not going to protect our patients against gram negatives or viral reactivations, things like that. So you still have to be very mindful about those things. and just not be, so the antimicrobial prophylaxis has to be more comprehensive than just, IVIG. It won't cover everything.
Well, that's an excellent point. I think, yeah, we harp on the IVIG, but then the prophylaxis, right, is still very important for antiviral prophylaxis and anti-PJP prophylaxis. Absolutely. And I guess there's one question that we haven't quite addressed is, when do you select using the bispecific by itself versus a combination like Tecdera? And is there a difference? And I guess I'll start with just saying that, if we want the bispecifics, all the bispecifics up until the Tecdera combination were approved in 5th line or higher. And really, it's the Tecdera combination that now is approved as early as 2nd line. So it's, in my mind, sort of a different scenario for that. I think where it becomes important is going to be in an early relapse patient who is DARA refractory. Does adding the DARA make a difference? And I think we'll get more information from studies like Majestic 9, which should be coming soon, right? Where you have the teclistamab single agent in a phase 3 study randomized to standard of care in 1 to 3 prior lines of therapy. If the combination is superior to what we see with the single agent, I think that might give us some pause in terms of like maybe we should be doing the combination, not just a single bispecific antibody. But again, how much of is the CD38 really augmenting the effect of the bispecific, or is it the anti-myeloma effects? I think that's where that's where that matters, in my opinion. All right. So I think we'll keep moving because we have 9 minutes. Boy, okay, let's go.
Yeah.
All right. So last section actually is just some practical tools for initiating bispecific antibodies in the community. And I'm going to pass it on to Dr. Usmani to take us through some of this data.
All right. So, we can go through the way that each of these bispecific antibodies are typically given, and some of the similarities or differences. So teclistamab is given subcutaneously, as is elranatamab, but teclistamab is weight-based dosing, whereas elranatamab is a fixed dose. So those are some of the differences. Linvoseltamab is a fixed dose, but it's given IV, so it's an IV infusion. So some differences in how you dose them, some differences in how you administer them. But each of them are given with step-up dosing to mitigate the CRS risk. So with teclistamab, you start off with a baby dose of 0.06 milligram per kilogram as the first dose, step it up to 0.3 milligrams per kilogram. And then the first, treatment dose is given, 48 to 72 hours later at 1.5 mg per kg. And then elranatamab is a fixed, first day dose of 12 milligrams, then 32 milligrams, on day 4, and then day 8, first treatment dose at 76 milligrams. Linvo is given at 5 milligrams as the first step-up dose. A week later, you give 25 milligrams. Then a week later, the first full treatment dose at 200 milligrams. So, in the combination trials, then the anti-CD38 monoclonal antibodies were added and planned concomitantly at the standard dose. So with DARA starting, once weekly, then going to, every other week and then monthly, whereas ESA, goes from weekly to every other week, from very early on. And that's how those clinical trials have been designed. So there is some real-world evidence, data that's out there about reducing the incidence of CRS if you give prophylactic tocilizumab. So this is an experience looking at the various bispecific antibodies and how when prophylactic toci was given, that there is a lower incidence of CRS, and it does not impact the response in patients. And what's not noted here, our group just published this paper last week of even using lower doses of tocilizumab at 4 milligrams per kilogram, not the 8 milligrams, and the 4 milligrams works exactly the same. Only 1 in 10 patients get CRS, and so you can give this in the outpatient setting. I think this is going to be very important for community colleagues to implement an SOP of managing these patients in the outpatient setting. And while we're talking about myeloma, the bispecifics are also, and of course there are, bispecifics for lymphoma already. There are several that are coming for solid tumor indications. We already have one for small cell lung cancer. So others are coming. So it's only a matter of time. Our colleagues will be using this in the outpatient setting with Profitosi for many other indications too. So let's test your understanding with this next question. So we have a 69-year-old patient with relapsed refractory myeloma initiating a BCMA targeted bispecific in a community practice. The patient lives alone, prefers to avoid hospitalization during step-up dosing. Based on the emerging real-world data, which of these would you prioritize to support safe outpatient initiation? Is it initiate tocilizumab at home if CRS develops, or initiate prophylactic tocilizumab to reduce CRS risk, or reduce the initial dose of bispecifics to reduce the CRS risk, or use extended prophylactic corticosteroids to reduce CRS risk? So please go ahead and pick your best answer. And you all are already, again, this is a very well-informed group because you keep on picking the right answer each time, which is wonderful. So initiating prophylactic toci to reduce the CRS risk is the correct answer here. All right, and then just like any other complex disease, this is a team sport. So we need multidisciplinary support to manage patients safely. It does take a village. You have your academic oncologist who are able to work closely with their community colleagues in making the treatment plan for patients and making sure that the transition is smooth. Pharmacists, NPPAs, our inpatient and ER staff, in case they are encountering these patients for management of CRS, they know exactly what to do in terms of interventions. Many times it's just an observation period, after giving TOCI or steroids for patients. And then, for other situations, such as infection risk, or, management of infections, you'll have ID colleagues kind of, joining. So having them part of the team is very important. And I can share my own personal experience if there are any Q&As. And then nurse navigation becomes very appropriate where they are available so that they can educate the patients to keep, not just patients, but caregivers too, on what to watch out for, and make sure that the care team knows exactly what's going on so that an intervention or, can take place sooner than later. I think this was supposed to be Dr. Berdeja's slide, and I just went on. But Jesus, please go ahead.
You did it so eloquently. We don't mind at all. But I guess I can just move on to the next. But basically, I think like you already said, I think this is where you really need to empower your patients and their partners, because a lot of the time is these subtle things that need to be picked up, especially by the people that know the patient the best. And so the more education for patient and their caregivers, the better outcomes, the more likely they are to get back to you timely. And then things like patient wallets, making sure they know the emergency contact numbers and all the symptoms that they should be watching out for are very important to make sure. I think here is intervening quickly will significantly decrease the potential of an adverse effect. And so I think right now at least in the initial time of when these drugs were approved, I think most patients were sent to academic centers for the initial step up and first dose. And it was very difficult to get patients back in the community to sort of take over for these patients. But, realizing that most of the cytokine release and some of these things that, seem scary really happened during the step up, it was very easy to, I think eventually sort of move on to letting the community take over afterwards. But as we're finding out, most of these patients are talking CRS grade 1. Now with the use of tocilizumab prophylaxis, now we're talking, instead of 60-70% of patients CRS, is down to 10%. So I think as this becomes easier, my guess is there'll be even less need to do that initial step up in the academic center and maybe incorporate it completely in the community center. And as Dr. Usmani said before as well, obviously you're using them in lung cancer, you're using bispecifics in lymphoma. So this just seems like a natural sort of uptake to do that for myeloma as well. And so I think actually that was our last slide. So we're going to open it up to any Q&A that please feel free to enter questions. So if we actually only have a couple minutes. We kind of went through a lot of the questions in that earlier section. But this is your opportunity to ask us if you have any. And it looks like some are coming in now. It says, for those of us in smaller practices, are you admitting everyone for step-up dosing, or have you moved to fully outpatient yet? And then how many hours of monitoring are required after each step-up dose, and for how long? So I think, I would say that that's actually a question for you. I think it's definitely, I think the larger practices, I come from a large practice, and so we've sort of decided to make 2 or 3 of our clinics geographically in geographic regions that make sense to be sort of the step-up dosing clinics, so that patients don't have to travel as far, but they still have to travel some. And then after the step-up, they're going back to their home clinic. I think that probably is harder in a smaller practice, but I think it's still doable. But I think as we alluded, with tocilizumab prophylaxis, I think we're starting to realize that maybe, most patients can be safely treated from the onset in outpatient. You just have to be really vigilant and have a plan as to what happens when those patients have toxicities. I don't know if Saad, you want to add to that, or if maybe go on to the next question.
Yeah, no, absolutely. So I think, we try to keep most of our patients outpatient, with Profitosi. But then if someone, does not have good caregiver support, they're older, or, they have other comorbidities, or they're coming in with high disease burden, I think, it's just safer for those patients to be admitted. So we've actually created an SOP with that regard. If patients don't meet any of those check marks, we try to get them managed in the outpatient setting. And then for the first, step-up dose in the outpatient setting, we typically don't want monitor patients beyond 4 hours. So it is, a monitoring period, but they don't necessarily need to occupy the infusion chair during that time.
Yeah. And unfortunately, we're out of time, so I think we're going to have to leave it there. But I do have to say, when somebody asked, would you be comfortable using bispecifics in frail older patients? And the answer is absolutely yes. I think these are therapies that can be very safely given to patients with comorbidities, even like patients with end-stage renal disease. So, and Dr. Usmani is also nodding his head, so I think he agrees. But with that, I think we're going to wrap it up. And thank you all for your attention. And again, you can download the slides from today's events, and here's some information for you to get your CMEs. And thank you for your attention.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.